Welcome, everybody, to Developmental Behavioral Pediatrics Live. If you're watching this today, you've got questions. You've got questions about a child or a loved one or somebody that you care for in regards to concerns of an autism spectrum disorder. This podcast episode comes from questions that we've received on social media in regards to what are the early warning signs that you can expect to see in a child who should there be concern for an autism diagnosis, and at what ages do you see them? This and more on this episode of Developmental Pediatrics Live. Okay, same rules apply. If you've got questions, comments, or concerns, put them in the chat or on the upload in the comments, and we will see them and do our very best to respond in a timely manner. This is, as I've said, Developmental Pediatrics Live. My name is Dr. Nate Noble. I'm a developmental pediatrician, clinical geneticist, and we're making these videos for parents and providers just like you who are on wait lists or thinking about being put on a wait list to receive services. There's not enough people doing this work, and there's a lot of people just like you who need answers to questions right now. So why not skip the line and join us every week at 9 a.m. Central, and we're going to do our best to answer the most common questions. All right. And again, don't forget to put your questions in the chat. That being said, let's get it. Early warning signs in regards to concerns for an autism spectrum disorder. Questions that we're going to answer in this video. What are the early warning signs of autism, and what should be done? Again, these questions came to us from social media. This is us responding to your needs as best we can. So don't hesitate to put your questions in the chat. That's what makes a live presentation fun. It's you. It's you. It's not me. So tell me what I'm missing, what you need, what you want, and we're going to do it. All right. So let's get into it. First thing you got to understand, I'm going to tell you something you already know. Autism is common. And let me quantify that for you. When I started in developmental behavioral pediatrics in 2007, the prevalence of autism within the population at that point in time was 1 in like 110. Okay. And then as I went through fellowship, the numbers increased. So then it became like 1 out of in 88, and then it became 1 in the 50s. Now it's 1 in every 36 children. Okay. Now you don't have to be very good at math to know that that is a lot of kids. Okay. And so essentially what that means is there's going to be a wait list for a lot of these types of evaluations, which makes these types of events so important. Autism, first and foremost, of course, is common. And the other thing you have to understand as well is that early intervention matters. Okay. And we got a question. Renee Cronin. Oh, look at this. Hey guys. Thank you for putting your names in the chat. I love it. Thanks for being here. Let me know what questions you have. All right. So, but back to what we're saying, early intervention matters. Part of the reason why there's so much emphasis, okay, there's so much emphasis on getting kids in and getting them seen quickly is because we have to provide a unifying diagnosis or a description in order to put together a plan of care. And sometimes this diagnosis is a key that can unlock doors that are very specific for individuals with an autism spectrum disorder as diagnosed by only a handful of people within your community. Developmental pediatricians, psychiatrists, some neurologists, psychologists. There's a handful of people who use standardized measures to diagnose these things. And the reason why there's so many waitlists is because early intervention matters, and we have to quantify the diagnosis to unlock the door to the therapy that's going to be meaningful. And not only that, but early intervention is also important because the younger the child is, okay, the younger the child is, the more neuroplasticity we see in the brain, which essentially means like the more quickly the interventions can kind of take root early in the process of language development. And so you see, better outcomes and longer lasting progress for children who are identified early, referred, and receive the necessary therapies and services. Now, let's talk about how autism presents at different age ranges. Let's talk first about the 6 to 12-month-old. Okay. Now this is surprising for people because they think, hey, how can we be how early can we be diagnosing children with autism? Now, I've never diagnosed a child under a year of age that I'm aware of, but we have some really nice testing strategies that kind of reach that 12-month age. The earliest I've ever diagnosed a child with an autism spectrum disorder was 16 months. Okay. And at that point we had enough information to be correct. And that was a lasting and correct diagnosis. But there are some precursors to being able to quantify this diagnosis. And you can see them as early as 6 to 12 months. Let me make this big. What I want you to think about. Okay. Now listen, as I show you these things. Okay. I'm not trying to incite fear and concern in you, right? You asked a question and I'm answering it. Just because you have a child or know a child or have seen a child who doesn't do some of these things, that does not mean they're going to go on to develop or be diagnosed with an autism spectrum disorder. Okay. So take that with a grain of salt. I love you. I care about you. So don't take this with a grain of salt. Okay. Let's get back to it. A lack of eye contact. Now, when you have a 6-month-old child, okay, now 6-month-old children, right, they tend to regard their environment, right? Their vision has improved to the extent that they can see things kind of out and about. I'm not smart enough to tell you like how well they can see, what distances. But what we do know is that babies that are in car seats, when you get up close, you go boo, and you move your head over here and you go boo, and they see you and their eyes get big and maybe you can get a little smile out of them. So that's what we mean here by eye contact. Children who you don't see that routinely in, or who have reduced social smiling, right? So you make a soft noise, you get close, maybe blow a little air in their face, you do something that's just gentle, just loving, just engaging. Usually you can kind of elicit a social smile. And if you don't see those things that come, easy between the 6 and 12 month mark, what I want you to understand is there may be a reason for additional evaluations. And it doesn't necessarily mean autism. It could mean the child has hearing or vision problems. Okay. It could mean a lot of other things. It could mean that they're in an environment where, they're not getting interacted with in the manner that's going to facilitate these skill sets. And so we need to encourage that. A lack of response to name. Now, do I expect a 9-month-old to always know their name, but, maybe not necessarily. I mean, every kids are a little different, but you would expect them to respond, right? Like you'd be, hey, Brian, hey, Jonesy. And you'd expect them, between 9 and 12 months to be like, what are you talking about? We got something happening over here. What do you got? A puppy? You got a bottle? What are we doing? You know what I mean? That kind of stuff. You've seen babies, think about babies in car seats that are close to a year of age. You know what I'm talking about here. A lack of these skills heightens our concern and underscores the importance for long-term surveillance through your primary doctor. Limited gestures. Okay. So by 12 months of age or so, children start to make some non-specific gestures. I'm not saying that every 12-month-old's like, give me that. I want that. But at some point, they'll be reaching for something, they'll kind of gesture towards something that's just out of their reach. They might even at some point, as they get closer to 12 months of age, kind of gesture for this non-specifically, and then just give you quite a quick look like, I'm in my high chair. I can see you over there. Get off your phone and get over here because I'm having trouble reaching the Cheerios. Like, get over here and give me the thing that I need now. And then minimal vocalizations. Okay. So boo, 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 boo. And then the baby's like, boo. They start making these razzing sounds. They start doing this like we're having a baby convo. We're having a talk. We're doing a thing, or I'm doing a thing, and now your eyebrows are up, eyes big, smiling. Now you're doing a thing with your mouth. That's the kind of back and forth information that we're talking about in the 6 to 12 month zone. Okay. So you can see these concerns early as it relates to children 6 and 12 months of age, but certainly not diagnostic. So let's keep the party going. And now let's talk about the 12 to 18-month-old. Let's talk about the 12 to 18-month-old and see what we can find here. When you got a child in this age range, you're starting to see the emergence of language. Okay. And by language, I mean, yes, there's communication strategies to utilize prior to this, but we're looking for things that are more measurable, more objective, things that you don't have to be a neurologist or developmental pediatrician or speech therapist to identify, like single words. So sometimes I'll just ask, how does he, when they're closer to 18 months, how does he or she communicate with you? This is a great question. How do they communicate? How do they make their needs known? How do you know that it's graham crackers that they want? Like, what is it that they do that helps you understand what is needed? No single words. Now, remember, just because you got no words yet, sometimes kids are not in a language rich home, and that's not a criticism. Sometimes people don't have time to be reading to the child or to do things that would facilitate these kinds of things. And again, these aren't criticisms, but kids respond differently when there's different levels of language that are used in the home. So read to your kids, talk to your kids. No single words, no pointing, no showing. Okay. So when you get to that 12 to 18-month-old range, you get kids that they're starting to use one of these bad boys. Like, hey, that's a dog. I'm looking at you. That's a dog. Get that dog over here now. Right. Or I want a graham cracker and you can get it from me. You have skills. I have needs. Let's put those things together and have a graham cracker party who's with me, right? So you're looking for pointing or showing like, hey, this thing lights up. Did you know this thing lights up? I'm looking at this thing. Look at this. I'm showing it to you. This thing lights up, right? You start to see these kind of sharing, these pointing out of things, these single word utterances. I'm telling you things. I'm asking for things. I'm helping you know that I want things. Kids that you're concerned about who potentially are on a path to developing an autism spectrum disorder, they're not demonstrating these skills in a timely manner, or they prefer objects over people. So you give a child a toy and they're more interested in the toy than the people who gave them the toy. And it might not even be the toy they're interested in. It might just be the wheel that spins, the button that pushes, that makes the annoying sound, right? These are kids that don't tend to diversify their toys, or they diversify to such an extent that they don't really focus on any one thing. I usually ask families, during their day when they're walking around your house, is there just a wake of unused toys behind them? There's like, here's a this, here's a that. I pick it up, I suck it, I lick it, I throw it, but these are cars that drive. These are, drums. These are things that you could take a minute and utilize, but sometimes kids just aren't interested, right? They value objects typically, okay, but they may in some sense value the object over the person. So now you bring in some nieces and nephews and the kid's there and they regard the kid maybe for a second, but now I'm just back to doing the thing. I'm pushing the button, spinning the thing, I'm walking around, I'm dropping that toy, I'm picking another toy up, and you're like, you're not quite getting the gist of what we're trying to do with these toys. Repetitive movements. Okay, I'm telling you stuff you already know. Kids tend to be pretty diversified in their motor planning, right? I'm doing this and then I'm doing that. But if kids get stuck in a loop where they're doing one particular motor skill set over and over and over, think about it. They're excited, they're scared, they're annoyed, they're bored, right? You put on a movie, you put on a TV show, you play a song, and all of a sudden it's like it's too much sensory input and it has to go somewhere. Like the pot overflows. And then you see it kind of come out like, I'm going to do this with my hands for a minute. I'm going to spin around a little bit. I'm going to look off into the corner. I'm going to see that ceiling fan. And I'm going to do ceiling fan. I'm just going to look at that for a while, right? Uncle's over here blowing bubbles. I'm like, whatever, uncle. Ceiling fan's what I'm doing right now. Okay. So that's what I mean. Okay. Repetitive motor mannerisms could be hands, could be toe walking, could be a lot of different things you can see in this age group. And listen, this is important. I got to make myself big. Don't get dialed in on this idea because a kid hand flaps a little bit or a kid walks on their toes a little bit. Don't get dialed in on an emergent, subspecialty evaluation. Kids can do this stuff. You and I both know adults who do this stuff and are doing fantastic. Okay. And we both know people who do this stuff and have an autism spectrum disorder who identify as autistic. We know this. Okay. But they don't correlate one-to-one. It's so important that you understand that I've seen so many kids referred from all the 99 counties across Iowa who, walked on their toes one time and did a thing with their hand once as they were shooing away a fly at a picnic. And everyone's like, oh, that's it. Get them to the thing. They've got autism. We got to do this. So please understand that some of these things can be transient. The kind of situations I'm looking for are the kids that are locked in these situations, right? I'm locked in here. I'm doing repetitive motor mannerisms. And lastly, okay, as we think about rounding out the 12 to 18-month-old, this is an important one. Kids in this age group have a way of getting in your business. Okay. And here's how I quantify that for you. They want to participate or they're curious about your delight. If you're laughing, if you're interested in something, if you're opening up a box, if somebody knocks at the door and you open it up and you look and say, oh my goodness, it's a this. Kids in general have an innate curiosity about what brings you delight or what brings you pain. You drop something on the floor and you scream. A snake, somebody, let's say you got a spouse and they trick you and like they have a fake spider that jumps out of a thing and Halloween, you're like, ah! Kids are going to be like, huh? What's going on over here? Sounds like I'm missing out on a party. What's the situation? Is that box for me? What are you looking at that phone? They want to be involved with you. And this grows as we talk about it in our next set of skill sets as kids get older. But I want you to understand that the precursor to this sharing of delight is imitation. Oh, you're digging a hole? Okay. Well, guess what? Time for me to do some digging. Oh, you're gonna do some push-ups on the floor? Okay, well, clear some space because I'm going to do some downward dog and then I'm going to get after this. I'm going to do some push-ups. They want to do what you're doing. They want to be in your business. You're stirring? Well, I'm going to push the thing over and get in and do the thing. So I ask families, listen, is your kid getting in your business? Is your kid getting in your business? And if the kid's not getting in your business, not doing the things that you do, not actively participating in the things that bring you delight, if they're not curious about that, that's concerning. If you open up an Amazon box and that kid doesn't immediately push its way in because the kid thinks it's for them, okay, put a pin in it. Remember that. Let's watch it and see what happens next. Okay, so that is what I wanted you to know about the 12 to 18 month olds. Now let's talk about the 18 to 24-month-old child. Let's make this big just for a second. Speech delays persist. Listen, this is important. Okay, here's what I want you to understand. Children who are diagnosed with an autism spectrum disorder make great progress. I hope you heard me say that. Yep, they do. People, I promise you, the only thing I've had several refunds in life. There's several things that I've done that I wish I could have done better, and people probably would have liked their time, energy, and resources back. But you know what? People have never, ever come back to this clinic, to my clinic or in my life. You know what they never asked for a refund on? Hope. Never. No one's ever come back and said, Noble said my kid was going to make great progress and he didn't. So I'm mad. No one ever says that. No one ever says that because hope is the engine that pushes us forward. What I say to families is, hey, listen, your kid's going to make progress. But until we figure out what's going on, until we put the right therapies and services in place, you can expect to see a plateau in their development. So if they've got speech delays between 12 and 18 months, those delays are going to persist until we start doing stuff about it. Next, they have reduced joint attention. What's that mean? You're looking at something. This is getting back to the point I made earlier about delight. You're looking at something and laughing. You're opening up the window and there's a hot air balloon outside and you're like, oh my goodness, guys, you got to see this dog. Dad's out on the sidewalk in a snowman costume and scaring kids. Like, look, watch this. That is what I mean. You're looking at something. A kid who is on track developmentally is going to push you out of the way and say, what's all the commotion about? Because it should be about me and it's not. So now I'm mad, right? So reduced joint attention. What are you looking at? I want to look at it too. What do I do about this in the clinic? How do I probe this? Kids playing on the floor. I say to the family, look, this is going to sound dumb. Don't get mad at me. Don't get mad at me. I just want you to say to them right now, Johnny, look. Johnny, look. And I want to see if Johnny will look up at the parent, see them pointing at something, and then be like, oh, okay, we're pointing at that. I just want to see, is there measurable joint attention? Can I see it with my eyes? Don't get mad at us. Don't get mad at me. I have to see it for myself. Reduced joint attention, repetitive play. Okay, we talked so you can see there's some themes here, right? The 12 to 18-month-old has a lot of repetitive motor mannerisms. But when you think about kids with repetitive play between 18 and 24 months, these are kids that you could give them their high preference activities, okay? So here's how I ask this question. If you take Johnny and you give him his highest of high preference activities, okay? So it's some Tupperware and it's some bubbles and it's a drum kit and it's a He-Man figurine. And you set him in his room, you leave the door open and you just give him the highest of high preference activities. What's he going to do all day? And if the families, typically what I hear from them is they say, well, he's going to do those things over and over and over and over and over. He's not going to diversify. He's not going to come looking for me unless he's got a need, or he just wants to verify my presence, or, he needs something to access that he can't access on his own. So it's not a shared enjoyment of things. It's not a come and play He-Man with me thing. It's you're a tool. I have something that I need you to accomplish for me. So please do that thing. And then once it's done, I love you. You're fantastic, but I'm done. You can go away. Right. So if a kid is good, if they're set and they're good, you give them their high preference and they're good all day. See ya. If that's what you're seeing, that's what I mean by kind of this repetitive play, this lack of pretend play. And you know what I mean here? I mean, cars drive. Okay. Figurines interact with each other. Okay. And so sometimes what happens, this is important. Sometimes what happens is people will say, well, oh yeah, he does that. Oh, she does that. Oh, 100% they do that. And I say, well, tell me about it. Well, they do this. They take this little figurine from Trolls and this little figurine from Trolls, and they do this thing together. And it's clearly like imaginary play. And I say, okay, are they reenacting a scene from Trolls? Okay. This is a nuance. And I'm not trying to diminish the awesomeness of that skill set, that emerging imaginary play skill, but imitating or mimicking or replaying something that they've seen somewhere else is not necessarily imaginary play, right? Imaginary play is you can swap out those figurines for Lincoln Logs. I could take my shoe off and I can make it a phone. So sometimes when I'm in the clinic, what I'll do is I'll pretend to take a call we have these little fake phones, and I'll take a call and I always pretend it's from Casey's. So if you're not from Iowa, Casey's it's a gas station where they sell pizza. And I'm always like, I pretend to take the call and I hold my hand. I'm like, excuse me, it's full. And then I put it down. I say, do you want pepperoni on your pizza? and then I hand the phone to them to complete the order. And of course it's fun. And sometimes it works well for the child. Sometimes it doesn't, but it just helps me to demonstrate this idea. Do you understand that this is a phone and it's not a real phone, but you know what the phones do and you can hold it to your ear and pretend to talk? That's what I'm after. And if I swap out the phone, I can give you a shoe and we can do the same thing. And then lastly, rigidity. Okay, now let's talk about rigidity. Here's what I mean. We all know rigid people. Some of you watching this are rigid, right? You don't like it when you have to wait too long. You get up at a certain time or blah, blah, blah. And there's people like me who I wish I was more rigid, but I'm not, right? But that's not what I mean. Rigidity here is, think about a pipe, a steel or a metal pipe versus a pipe cleaner. Okay, most of you are rigid, but really you're pipe cleaners. You can kind of, they're fuzzy and they bend and you can kind of do something. But rigid pipes, they don't bend. Right. So if I have a plan to go outside at 9:00 every Tuesday and it's 30 below zero in Iowa and it's death, outside equals death, then I'm going to melt down. And I don't care. I don't see it from your perspective. And you're thinking, well, that's kids, Noble. Yeah. Okay. So let's swap out weather or going to the zoo. Let's swap that out for yellow cup. Has to be a yellow cup. Has to be yellow cup at the right time. Has to be 4 graham crackers and not 8 or 2 or 7, right? These are kids that if I babysit them, there's going to be unspoken rules and I'm going to put my finger in it big time. I'm going to put my hand in the blender and you're going to be at the Civic Center watching the Newsies. And I'm going to have to call you every 15 minutes because Johnny's got snot dripping down the side of his face because I gave him 2.5 graham crackers instead of 3. That's what I mean by rigid. Okay. It's unspoken rules and unwillingness to waver. No way. So these kids, because life has a way of breaking rules and being difficult and not following routines, these kids melt down. So now when you're in this age range, meltdowns become a primary problem. They become very difficult to navigate in grocery stores. Everything becomes increasingly problematic because of their rigidity. And now let's talk about the 2 to 3-year-old. This is the last age range that we're going to talk about. Then we're going to move on and talk about what we're going to do about these problems. But as always, if you have questions and you're watching this on the upload, put your questions in the comments. Tell us what you want to know or what you hate or what you love. If I've learned anything about YouTube, you hope there'll be plenty of people who put in things they hate. So thank you in advance for that. But if there's actually somebody out there who wants us to do a better job and has information on what you want us to address, put it in there and we'll do it. And then lastly, of course, as we continue to move through our time together, you got to like and subscribe or no one ever sees this stuff. It's ridiculous, but it's true. So let's get back at it. The 2 to 3-year-old. Okay, let's make this big so you can see it. Here's what you have to understand about the 2 to 3-year-old. You expect a higher level social skill set between 2 and 3 because now we're out and about. We're in and amongst. We're rubbing elbows. We're like doing toddlers social media, not really, but like we're meeting and greeting, we're liking and subscribing, we're sharing popsicles that we've dropped on the floor, we're at daycare, we're at a family reunion. But these kids that are concerned, have concerns for an autism spectrum disorder, they have limited interest in interacting with children their own age. They may regard these children, they may see them, they may give them a subtle nod like you do to people at at Home Depot, but they're not interested in drilling deeper on, hey, these kids are running in a circle on the playground. I'm going to join them. This is an important point, and let me make it quickly. There are kind of two types of children who stand on a playground, okay? One kid stands on the periphery of the playground. There's two kinds that stand on the periphery. One stands on the periphery because they're not interested in what's happening, right? They're at the periphery because you put them there. They might see kids, they might wander through the crowd, but it's not to find a way to join in on the festivities. It's to explore something that only they're interested in, or more likely to put something in their mouth, right? Or to wander off. Like, you got to watch these kids like, whoa, Johnny, you can't get into the UPS truck, brother. That's not what we're going to do here. We came to play at the playground, not disappear, okay? So that's the first group, the kids that are on the periphery. They're just they see what's happening and they're not super interested. The second group of kids that are on the periphery see what's happening, but don't necessarily have the skill sets to join in, but want to. So these kids are what we're going to call joiners. So once you get them started, right, they're going to follow along. They're going to copy what other people are doing. They might not be a leader. They might not be winning friends and influencing people. They might not be, giving speeches to all the people on the playground, but they're engaged. I'm a follower at this point. And usually that's because they don't have speech language skills that can facilitate social interactions at a developmentally appropriate level, and they know it. They still have outbursts. They still blow up. They still struggle with transitions and unmet expectations. But when you put them in social settings, eyebrows up, eyes big, I see what's happening. I'm a joiner. I follow in. I'm going to be the caboose. I'm going to follow these kids up and down the slide. Those kids need speech therapy. Those kids may need a cognitive evaluation, but I'm less concerned about an autism spectrum disorder in that population. So they have limited social interactions. They have over or under reactivity. Let's talk about what I mean. These kids either overreact or underreact. Quick story. If I take these kids, one time I took my kids to a monster truck rally and we went without ear protection. I don't know what I was thinking. I mean, we could have been deaf. It was so loud. Some kids that you see are underreactive, meaning you could take them to a monster truck rally and they don't even care. Like, they're just like, I don't even hear anything. I'm just like, what I got to do to get more of this pretzel, right? But then other kids, they are overreactive. The same kid could be underreactive at a monster truck rally, but if you take them into a garage and they hear one cricket one time, that's it. That's an example of overreactivity. So sometimes the lights are too bright. Sometimes the snow is too cold. The wind is too fierce. I just can't get over it. But yet I can, I can get a burn on my hand and barely react. I can get my fingernail kind of, crunched in a door, and I might cry for a second and I'm fine. But if there's a cricket in central Iowa, I'm going to cry for 6 years. Okay. That's what I mean by over and under reactivity. Repetitive language. So now you might hear words, and you might even hear words that sound functional. Okay. So an example would be like, they might take a phrase that they've heard from something that they watch on YouTube or the television, and they might find a way to insert that phrase in a manner that seems to make sense. What's your name? And I'd say, oh, my name's Nate. What's your name? And they'd say, what's your name? Like, they know that question goes at the beginning of a conversation because they saw it somewhere. And the family say, see, he's talking, he's doing great. And I'm like, well, yeah, but I like that it's there, but it's not super functional. So maybe we need to lean in a little bit on the functional nature. So just because there's words, are they repetitive words or phrases, and are they functional? Right. So if you might get it right the first time, what's your name? But then I say, my name's Nate. What's your name? And so now it becomes non-functional. They come back. What's your name? Say, my name's Nate. Say, my name's Dan. Like, well, okay, like I love that people have been working with you and I get it, but this is not super functional, right? So that's what I mean. Repetitive language, restricted interests. Sometimes it gets more and more locked down. So I'm less and less interested in the other toys that people get me for Christmas. I'm more interested in the wheel on the train. It's not the train, it's the wheel on the train that I really, really want to deal with. And then not understanding expressions. The 2 to 3 year old, people say, well, they're not empathetic. And I'm like, well, I'm raising 4 children. Children in general, not super empathetic. I don't think, they don't seem to be super empathetic about, what's going on with you or me most of the time. So that's not necessarily the best way to think about it. Think about it's not empathy I'm after. It's not understanding expressions. Okay. Now, so sometimes what I'll do in the clinic is if the kids are older, I'll say, what am I thinking if I'm doing this? And they'll say, scared. What am I thinking if I'm doing this? You're angry, right? I'm asking them to kind of read my face. I was doing that one time with a kid. I go, what does it mean when I do this? And he goes, ugly. I go, yep, that's probably about right. Get out of here, kid. But example is like they tend to be able to interpret facial gestures, okay? Because there's certain things that we do, and this can vary by culture, but there's certain things we do with our faces that send messages to children. If I'm crying, if I'm grimacing, I'm holding my finger, I'm hurt. Children can understand that. Now's not the time to have a fit because you want 2.5 graham crackers. Something's happened. The focus shifts to, ooh, something's happened. Ooh, I should maybe not do that. If everyone's laughing, the child may look up. I hear laughter. I see smiles. I'm going to smile too. Like I get the joke and I don't. You know what I mean? They're joiners. They want to be a part of what's happening. So you'll see them in children who struggle in these areas. They struggle to accurately interpret facial gestures and the mood or the ethos of the room. They struggle. So now let's talk a little bit about what should be done. It's one thing to talk about this stuff. I tell families all day, every day, listen, the diagnosis of an autism spectrum disorder does take skill. Okay, it does take a fair amount of skill, but in general, I would submit to you that it takes less skill to answer the question of whether or not a child has autism. It takes astronomically more skill to answer the question of what are we going to do about this? The sleep issues, the transition problems, the self-injury, the lack of communication, the cognitive delays, the insomnia. What are we going to do about it? Now, it doesn't mean there's always quick fixes. That's not what I'm trying to say. But when you think about stepping into the deep pool that is autism care, you have to ask, it's not just about what's going on. You need to ask your providers, what are you going to do about what's going on? Okay. Nobody goes to a mechanic just to find out what the problem is. Oh, thank you. I didn't realize it was the alternator. See ya. Nobody does that. You need providers who are going to lean in and help you figure out what you're going to do. So let's talk just briefly about what I want you to do if you're concerned. All right. Let's make it big. Okay. Now, of course, some of these things you've already thought of. You're going to talk to your primary doctor. You've got one. Are they a developmental pediatrician and geneticist? No. Do they need to be? No. Just go to them and say, I have these concerns. Pediatricians, family practice doctors are amazing at screening for these things. There's standardized tools that they can use on a surveillance level that will indicate risks and help us direct what comes next. So it's so frustrating when I bump into people and I'll spot it. I'll be at the mall. I'll be at Home Depot and I'll see it. And I know, okay, I don't know what's going on with this family, what kind of resources they're plugged into, but there's a problem here, and they'll come up and we'll talk about it sometimes. And it's like, have you talked to your regular doctor about this? Like, well, no, they're really hard to get into. I'm like, hard to get into. I get it. I believe they're hard to get into, but you know who's really hard to get into? People like me. Not because we're special, just because there's not very many of us. So start with what's accessible. What should be done? Go to your primary care provider and say, look, I have these concerns. And listen, can I just give you one more piece of advice? Don't beat around the bush. If you have concerns for autism, say, I have concerns for an autism spectrum disorder. Why do you have those concerns? Write down a list and tell them, I watched this guy on YouTube. You should go watch the thing about the thing. And then be specific, because sometimes they're like, well, Einstein was a late talker. Listen, I'm sure it was a late talker, but he turned out okay, right? But the thing about it is, just because Einstein was a late talker, or like your child has an older sibling who's a late talker, that doesn't excuse the concerns that we have over the last 6 slides. This is something that we don't get to brush away. We don't get to ignore. We have to think about. So the next thing after you talk to your primary care provider is you can start doing stuff on your own. You can request an evaluation by an early intervention team. What do I mean? Every state has a different term for this, okay? Every state has a different word or phrase that they use to describe federal dollars that come to the state to provide services in home or daycare for children between the ages of 0 and 3. Okay, after they turn 3, those services change names and those kids then continue services in a public preschool setting at no cost to you. So you want to be a part of this system. And guess what? You don't need a referral from your primary care provider. You do not need a referral from your doctor to get these services. You can call your local public school, right? Think about the school that's in your district. Think about the school that's across the road from you. You can call the office and say, I have a child, they're 2, I want an evaluation with your early intervention team. What do I need to do? And they will direct you. Okay. They'll give you the information. They'll say, call this number. And then within 6 weeks, somebody will schedule a visit with you. This is not a diagnostic visit. Okay. These people are not coming in to diagnose things. They're coming in to determine if there's enough delays in certain areas to qualify for skills that they can provide to you at no cost in your home or at daycare. You can make that referral yourself. Hearing and vision. You need to think about a hearing and or vision evaluation. The early intervention team will screen your hearing of your child for free. Okay. Your pediatrician or family practice doctor can do a very cursory vision evaluation as well. And if there are concerns from those screens, then of course a secondary assessment is necessary, but sensory and or vision difficulties need to be interrogated because children who can't hear or can't see will very much present with a social and emotional delay that can look a lot like an autism spectrum disorder, and it's not. Speech evaluation. Let's talk about this. Let me talk about this. Now, early intervention, if you line that up, right, you make the call to the preschool, you say, get over here, kind of thing, and they start doing speech therapy for you in your home or daycare. That's only one side of the coin. There's another side of the coin, okay? Early intervention and kind of the educationally based model of therapeutic interventions tends to be, just as I've said, educational. So they're awesome and they're fantastic, but they're not meant to carry the entire therapeutic burden of every child with a neurodevelopmental disorder. You need the other side of the coin, which is primarily thought of as the medical model. Now, that's not necessarily better. It's just different, right? So you've got early intervention doing speech therapy at daycare or at your house, and then you going to a speech therapy clinic as billed to your primary insurance. Okay, so you may have a copay, you have to deal with your insurance carrier, but these are things, and these things require a referral from your doctor. So don't feel like you have to leave your doctor's office with, your doctor saying, well, we do have some concerns. Let's see in 6 months. You can just say, hey, let's get a hearing and vision evaluation. Tell me, do you have any information on the early intervention team? Can you make a referral for speech therapy for me? Because, and this is important, because oftentimes speech therapy visits can take a long time. They have a lot of backlog, just like I do. They might see you in 2 to 4 weeks or, a month or 2 for an assessment, but an assessment is not a therapy slot. A therapy slot is when they're seeing you weekly and working on skills and abilities. And in Des Moines, probably like a lot where you're watching, the therapies can take a long time. So why not just have your doctor make a referral to a local speech therapy organization? There's occupational therapy services. We're not getting into that, but they're amazing for fine motor or sensory difficulties. There's physical therapy services for gross motor skills, standing, crawling, walking, sitting, these kinds of things. And oftentimes all these individuals cohabitate. So depending on the skill set of the child, think about referring to all of those specialties, but your primary care provider can do this for you. But now you're going to say, but Dr. Noble, the doctor doesn't know what diagnosis to use. Okay, let's just lean in close. Look to the left, look to the right. Here's what you tell them. Tell your doctor you need a referral for a speech therapy evaluation for the diagnosis of mixed receptive expressive language disorder. I should have put that on a slide. I didn't, but this is the good. This is why you watch the video all the way through. This is the juicy stuff. Just say to your doctor, don't use the word delay. Tell your doctor, don't refer for speech delay. You know why? Because your insurance company will say no. They'll be, nope, delay is not bad enough. Don't ask me why. I don't know how they determine this, but they do. Have your doctor make a referral to a speech therapy office for a speech disorder or mixed receptive expressive language disorder or expressive language disorder, but it has to have that term disorder in it, okay? Just tell them. Google it, doctor. There's an ICD-10 code out there. You'll find it. Link the referral to that diagnosis and pew, away it goes. Listen, it's important. You've got to learn to self-advocate. You would think that we as providers would be better at this, and your provider's doing a great job, but it's really, really hard. You know, the visit just before your provider might have been figuring out pneumonia or asthma or diabetes, and now they're stepping into a neurodevelopmental disorder. Give them a break. It's really hard. You're going to have to lead that conversation. Ask for a speech therapy referral. Link it to a speech diagnosis that has the word disorder in it, and you're going to be okay. Lastly, think about a developmental pediatric referral, somebody like me. As I've said, you're better off, okay, to get in line. You don't have to, let's talk about movies. Let's talk about the State Fair, okay? You don't have to know that you want to see the movie. If the line's really long and you've got time on your schedule, just get in line. Just get in line. And then you can think about it as the line moves, decide if you want to go see Moana, make the choice, right? But if you don't get in line, then if you do decide you want those services, now you're 6 months behind. So just go get a referral to the developmental pediatrician. If you do think there's a big problem here and you want to get out ahead of it, just ask your doctor. Say, listen, can you make a referral for speech therapy and for a developmental pediatrician? And then they're going to say, well, Noble's got a 1.5-year wait list, or Shifsky's got a 9-month or whatever it is, or they've all these folks have really long wait lists. But listen, it's okay. Just get on the wait list and then we can clean it up later. Worst case scenario, you make a referral, you go about your life, a month or two before your scheduled evaluation, you decide it's not needed and you cancel. A wait list is a cure-all for many, many things. Sometimes you just need to make the referral, get on the books with some therapists, and things get better fast. Okay. So what's next for you and me? What's next for you and me, right? This feels good. I like talking to you. This is great. But let's talk about what's next. Listen, here's what I want you to understand. This is super dumb, but it's awesome. All the stuff you see on this slide is free to you. Okay. We're giving stuff away like crazy. Why? Because we've got to find new and creative ways to get information to people. Okay. And so we've got courses coming up in 2025. If you're a parent, if you're raising a kid, if you're a teacher, whatever you are, and you want to spend 60 to 90 minutes with me, asking me questions and going through very specific things, there's a few things that you need to think about. First and foremost, join our newsletter. I mean, every week I put out a video newsletter and I just talk about problems that I'm trying to help you solve. Maybe it's dumb. Maybe you hate it. Just delete it, unsubscribe. I get it. But you're also going to get information on stuff that we're doing. Like, hey, there's an autism. The 5 pillars of autism is a course that we're going to put out in 2025. It's 5 pillars. It's the 5 things that you have to know, that every parent needs to know. And some of them are going to make you mad and some of them you're not going to want to talk about, but you need to know it. I've said the 5 things for 10 years, longer. I've said the 5 things over and over and over again, and you need to know it. 60 to 90 minutes. You'll register for it. I'll email you some stuff. It'll be great. And then how about this one? Why not join me for How to Parent Like a Pro Wrestler? Hey, you tell me that's not a course you want to take. You tell me you don't want to know how to parent like a pro wrestler. Okay, it's not violence. It's all the pageantry. It's all the understanding that somebody's going to win and somebody's going to lose, and that's been predetermined. It's all the spandex. It's all the glam and it's all the things you think. It's me walking through how to not make behaviors worse as you begin the process of trying to make them better. And I will tell you, there's a way to do it. So if you're on the newsletter, you're going to learn about all these things and more. That being said, I want to thank you for your time, energy, and resources. That will do it for today. But before we go, we got a question. I love you, create these videos. That was very nice of you, Kendra. I really appreciate you saying nice things to me. Most times when I do these things, people to say mean stuff. So thank you in advance, and please share this. Here's a question from Tracy. Our son's speech improved so much with therapy that we were able to transition out years ago. Yes. Now he's in the puberty stages and we're noticing significant speech issues. Again, is that pretty normal as his brain and body is changing? Should we seek out a speech therapy evaluation again? Great question just yesterday. So another course that's going to be coming out is puberty. Puberty in regards to autism, because that you see a lot of decompensation and struggle there, and people need to know like what to anticipate and when. So that's a course we're going to be putting out in the future as well. But back to your question, puberty in general is kind of like a seat back, upright, tray tables in the locked position, put your seatbelts on. It doesn't matter what I say next, Tracy, things are going to be bumpy. Okay. Now, and teenagers in general, for whatever reason, tend to have some kind of developmental regression in regards to expressive language skills. They go from I'm articulate, I can speak in sentences, to grunting. Or they put bro at the beginning, at the end of everything they say. I don't understand it. I think you all know what I'm talking about. So irregardless of whether there's a neurodevelopmental disorder, as a teenager, you're going to experience some language regression just because, I don't know, some parts of their brain just shut off. I don't understand. It's very hindbrain. I don't get it. But to your more specifically, I'm not aware of anything that would result in developmental regression in puberty, unless, of course, we're talking about scary things that I don't think that you have. But please know that bad things are greedy. So, and this is maybe more than you're asking. If you've got a child who's losing skill sets, they're losing skill sets. You have to understand the bad things are greedy. Bad things are not picky. They're not like, I'm just going to take some language and I just want a little bit of saffron. No. Greedy things take everything. They gross motor, fine motor, language, adaptive skill sets. Everything just kind of withers away. And that's not what we're talking about. Probably what you're talking about is language. But now to more specifically to your question, should you think about speech therapy again? And I will tell you, I love where your brain's going with this. And I also would tell you there's probably a bit of wishful thinking there. Okay. Speech therapy clinics are super busy, and it's unlikely that they will have slots available for teenagers. Now that's sounds worse than it is. I don't mean to say that. It's probably just me thinking about what I know in central Iowa, but that tends not to be the demographic they're serving. Typically, when you've done speech therapy early and often, you graduate and there may be seasons of plateau, but plateau is different than regression. Plateau is different than regression. Doesn't mean you're going backwards. It just means you're not going forwards very fast. Okay. So I don't think a speech therapy assessment will be easily accessible, but that doesn't mean you shouldn't consider it. I would start with school. Because listen, if this kid has speech language delays and it's becoming problematic from a functional standpoint, this child will likely benefit from an assessment through the we call it in Iowa, the area education agency. It's the school arm of early intervention. They'll do an assessment at school. If he qualifies for speech therapy, they'll provide it at school at no cost to you. At no cost to you. What's most likely is they'll do the assessment and your child won't qualify because they'll be good enough. They'll be on the bubble. So then you're left with, well, maybe we should seek a speech therapy evaluation. It's not wrong to talk to your primary care provider. It's not wrong to make the referral. And if he gets a therapy slot, I think that's amazing. But remember, just because you can do stuff doesn't mean you should do stuff. That's once a week. It could be once or twice a week. There's a lot of commitment that goes into that. But if you're concerned, you're a good parent, you're a smart parent, keep after it and don't quit. Okay, that's a great question. And if I don't see any other questions, this is so fun. I absolutely love talking to everybody. I'm going to put my 80s music on, and I'm going to say goodbye to everybody. I'll see you next week, 9 a.m. Central, and your questions.